This is SiriusXM Dr. Radio.
You're listening to Dr. Radio Reports. Coronavirus. What you need to know now. Here again is Dr. Mark Siegel.
Welcome back to Dr. Radio Reports. Coronavirus, COVID-19, the pandemic, what you need to know right now. I'm Dr. Mark Siegel, Medical Director of Dr. Radio, Clinical Professor of Medicine at NYU Langone Health, author of a forthcoming book about COVID, the fears, the science, and I'm joined by someone that's going to help me with the fears today. Dr. Jeffrey Lieberman is a friend of mine. He's the Lawrence C. Kolb Professor and Chairman of the Department of Psychiatry at Columbia University College of Physicians and Surgeons. I've known him many years, and he's very articulate. And Jeff, thank you for joining us.
Sure, Mark. Pleasure to be back with you.
You started to talk to me about the tsunami of mental health issues that we're facing. Tell me about this, the undiscovered country, what we're not talking about and should be.
Well, you know, the disaster that we're currently contending with is really an infectious disease. And the infectious disease has to be fought initially on the level of prevention through distancing, masks, sterilization, disinfectant, precautions like that, in lieu of having a vaccine until treatments that can prevent it from producing significant morbidity and mortality occur. Those will occur, but it's taking a while. What's not being appreciated is the aftermath and what's going to result from it. People will have died, so we'll have lost people and they'll be grieving. Other people will have been really sick, and that will affect their ability to pursue their lives and their families when they've recovered. But everybody is going to be affected by the psychological consequences of this. And that's something that, although there's pretty widespread agreement of, there's nothing being done to try and take actions to preempt it. And we know from what is really disaster psychiatry or disaster epidemiology studies that have been done over the years on natural and man-made disasters of what these sequelae, what these consequences are. And we can quantify them, and we can also identify what groups are most at risk, and we know how long they last and what they result in the way of substance abuse and suicide, domestic violence, criminal violence as a consequence. And so we can actually estimate what the impact of this is going to be, which is going to be bigger than Hurricane Sandy, than Katrina, than 9/11, but we're not doing anything about it. Your program, by trying to focus on this topic, is spreading awareness, and the message that I want to make to you and ask you to carry forward, because you have many opportunities in the media, is that we can't just talk about it. We have to start planning to do it, or we're going to basically make the consequences worse than they need to be.
I want to do a huge deep dive on this, and let's start with people that don't have a diagnosed psychiatric disorder. And let's say this. Let me give you a couple examples off the top of my head. I've studied fear, as you know, and I'm doing an updated version of this, and I think fear is a factor here. Fear is corrosive. So how about a situation where you have elderly parents, right, and you don't want to see them because you're afraid of COVID, but the numbers are going down, and they're isolated, and they're depressed, and they're anxious. Shouldn't you be kind of compromising and saying, what is the risk of me infecting them with a virus that's diminished now, I'm not in a hot spot, versus what is the risk of somebody being isolated and depressed? Can we make those kind of equations?
Yeah, but it has to be done individually. First of all, this crisis is bad for everybody, but most people have the necessary resilience, and they don't have the pre-existing vulnerabilities in terms of mental disorders, so that they will be able to withstand the effects of it, unless they're particularly hard-hit, meaning that they're in the ICU, intubated for some number of weeks and escape barely with their lives, or they lose loved ones who die and are going through a prolonged grieving process. Most people will withstand it, but many people won't, and more won't, and experience PTSD, depressive conditions, mood disorders, and anxiety disorders in the aftermath than are the usual population frequencies because of this added stressor they're experiencing. And the people from past studies from Katrina, from Sandy, from 9/11, from earthquakes show that poorer people tend to be more affected, older people tend to be more affected, children and pregnant mothers tend to be more affected, and this is the key thing, Mark, you can't prevent the natural disaster maybe, but you can mitigate the consequences by, one, responding to it, FEMA or other means, quickly to provide some type of demonstration of support, even if it's not complete restoration. And two, providing some mental health services in the aftermath. This is a huge factor in limiting whether the emotional devastation is 100% impact on people or a 50% or 20% impact on people. And so as part of the usual disaster aftermath policies or initiatives that are put into effect, there should be a comparable and equal kind of mental health one. You don't just rescue the affected people and treat their injuries and enable them to recover physically. You have to help them to recover mentally also.
Jeff, what about, you got into something I want to get a little deeper into, which is, and again, if I position this the wrong way, it's because I'm not at your level as one of the world's leading psychiatrists. What about when you start talking about socioeconomic issues, and you said that maybe there's even more of a need in socioeconomically disadvantaged areas, which I really think is a really important statement. What about the issue of online learning and online interactions? And, you know, we've made that part of the fabric of our society, and we're constantly criticizing it, but maybe it's really saved us here. Is that a problem in areas that are more socioeconomically disadvantaged, to not have access to as much online interaction?
It is a problem, and it's also an opportunity. Mark, you know, you should really get into a health policy, a Surgeon General or HAC, because you're thinking the right way. You're thinking in terms of public health, in terms of public mental health, and to do that, you need to be able to use these kind of mass communication mediums. So part of the problem that we had when we converted almost overnight from, you know, in-person, on-site healthcare delivery to telemedicine it was that people who had smartphones, people that had iPads and laptops and were somewhat computer literate had no problem. But people in lower socioeconomic groups, less educated, poorer, they may still have flip phones, or even if they had smartphones or even computers, they didn't necessarily know all of the process of how to sort of access certain programs or certain websites or certain URLs on the internet. So what that, you know, pretty quickly indicated was that in terms of implementing the 21st century version of telemedicine, telehealth, part of the process is educating the patient about how to use these things, which is not rocket science. It's not that hard. My 96-year-old mother is doing it. But the thing is it required something to be done that isn't usually done. So initially, out of the gate, the less economically advantaged, the less educated are at a disadvantage. But by providing them with a minimum of technical assistance, you can automatically expand your reach enormously. And you know, one of the things that we found out was that the no-show and cancellation rates on appointments was much less. And the frequency of the treatment, implementation of the treatment adherence was much better. So this is something that really offers a great opportunity, but we have to enable people to overcome whatever their technical limitations are in order to be able to utilize it fully.
You're listening to Dr. Radio Reports, the coronavirus pandemic, what you need to know right now. I'm Dr. Mark Siegel, Medical Director of Dr. Radio, Professor of Medicine, NYU Langone Health. I'm joined by a friend of mine who I've known for many years, Dr. Jeffrey Lieberman. He's the Professor and Chairman of the Department of Psychiatry at Columbia University College of Physicians and Surgeons. If you'd like an opportunity to talk to one of the top psychiatrists in the country, I'm also quite friendly with our own Chair of Psychiatry, Dr. Marmer, by the way. I don't want to leave him out. Give us a call at 1-877-698-3627. That's 1-877-698-3627. Dr. Lieberman just said that he has a 96-year-old mother who's in great shape, and I'm so happy to hear that. I have a 96-year-old father and a 95-year-old mother who are both in great shape and weathering this pandemic. Jeff, how do we deal with...
Mark, sei gesund.
And to you as well. How do we deal with people that have mental health diagnoses? How are you dealing with outreach? Does telepsychiatry play a role? How are we reaching people that are more vulnerable and more withdrawn now because of the pandemic?
Well, there is really a manual that could easily be communicated broadly as to what people should look out for and how do they know what their particular risks are. So everybody's going to be bummed out by this, and that's just, part of the deal. But most people have the means to sort of withstand it. On the other hand, everybody has their breaking point. So nobody is immune if this thing gets really bad and, like the stores are barren, there's no food, we have to start stockpiling. But most people will be able to withstand this, even if it lasts, a year in this particular kind of unusual sort of state of existence. But people that have pre-existing disorders will have exacerbations of their symptoms, and those will require adjustments in their treatment. And they have to be able to reach out, connect, and get the additional support they need from their providers, even if it's not necessarily face-to-face. And the providers can't say, I can't render service unless I see you. That's 20th century. This is 21st century. But beyond that, people who are particularly adversely affected, they lose their job because of this. Their kids can't go to school, so they're stuck at home, and the mother or father, maybe single mothers, can't contain and provide for everything. These people are going to be driven to the brink, and we've already seen an uptick of suicide, we've seen an uptick of substance abuse, and we've seen an uptick in domestic violence as a result of this. So these things are possibilities for people that are trying to cope with the disaster, but have limited means to be able to do so. This is where social services could come into effect. And then the other thing is that there is going to be a longer-term effect on a generation. And it's going to be probably the elderly and the children that are going to be most affected. And the elderly, because they're most prone to things that eliminate or reduce their need for support. You mentioned before the visitation by children, the emotional connection to loved ones and friends, which they won't be able to have. They won't be able to go out to exercise. They may not be able to get food in the same way that they ordinarily would. And there's already the highest rate of suicide of any demographic in our population is in elderly men over 65. So they're a great risk. And children are a great risk because this generational effect of an interruption in their schooling, which is not just education, it's the socialization by which they learn how to mature behaviorally and become cooperative citizens that can be productive and have good, healthy social relationships. This is being interrupted. And it's like, the Dutch hunger winter was something that affected a generation of children in the Netherlands. There are events that occur during periods of great influenza where this has happened in the past, where you have a generational effect. We're going to experience this, and it's something that's knowable and is being discussed, but as I mentioned before, I'm sorry to perseverate, we're not doing anything about it.
You're not perseverating, Jeff. This is so important. Let's go to the phones. Kathy in Tennessee, welcome. You're on the same topic as our guest, Dr. Lieberman, head of psychiatry at Columbia. What can we do for you?
Well, I'm just thinking about the poor little people in the nursing homes that have 2 and 3 shifts of nurses and doctors that come in and take care of them. How come, I just don't understand why their families cannot come in if they are checked, if they wear their masks. And, I mean, it's so important for their mental health, and yet they're just not being allowed to come in.
Well, Kathy, they are being allowed, but only in a limited basis. So initially when, at least, and this varies geographical region by geographical region, initially when New York was really under siege, there was no visitation whatsoever. And you were having people that would die in the hospital, maybe with a doctor, a nurse, or somebody holding a phone to their ear or using a smartphone with FaceTime. But there was no visits. Now there are visits, but it has to be done on a very limited basis. You have to restrict the number of people that can come in at one time. They have to be checked with temperature monitors and filling out forms at the hospital entrance before they are allowed in. So it's just, it's not optimal, but there is some degree of visitation. Apropos that comment, though, after the Chernobyl disaster and the Fukushima nuclear power disaster, one of the things that was found to be a very strong consequence in studies was that there was compassion fatigue among caregivers, particularly for older people. So this is something that I'm sure is occurring in the nursing homes now, as well as for people that have elderly parents that they're living with and have to provide care for. So that's another sort of aspect of the mental health consequences of this crisis.
Thank you for your call. Jeff, what about substance abuse? How are we doing with that, and what are you anticipating?
Not good, not good. I mean, it's definitely increased. The question is, what's the substances that people are using? Most commonly, it's alcohol, but cannabis is being used to a greater degree. Opiates are being used to a greater degree now. And so whether this rolls up to increased rates of addiction, overdoses, and deaths remains to be seen, but there's absolutely no question that there's increased rates of substance use. And the other thing is that people are seeking more relief through psychotropic medications from their doctors, and that's not bad. That's the appropriate place to go. But if they can't obtain something from their doctor, or they don't have a physician to request that from, then they're taking matters in their own hands and they're self-medicating. So this is going to be something that we're contending with. On one hand, you could say, well, Jeff, what are you so worried about? It's good for your business. We don't want this business. Our job is to put ourselves out of business.
What about schools and universities? I'm so concerned. I mean, schools are kind of still a question mark, but all these universities that are going online, people taking gap years, traveling around the country, including my own family. I mean, it's just, what's the psychological impact of all these school closures? It's a mess. It's a mess. I mean, we really have screwed things up. You can blame it on China, but the reality is it's out there, and it could be really, really bad, or it could be something that we sort of stepped in and got and limited in the nick of time with smart moves. We haven't done the latter, and we're suffering with the former. And part of it is the fact that it's disrupted education at every level. Now people have to make the decision, because universities have in some cases given the students choice for on-site versus stay-at-home virtual. And so they've left it in the hands of the parents and the students to decide what to do. But even if they go to campus, it's not going to be the usual experience.
and it shouldn't be the usual experience, because if they start doing the same kind of social activities as normally would have been the case, that's going to jeopardize the safety precautions and limiting the spread of the virus. So there's no solution. Frankly, Mark, I think while we sort of are attempting to use good judgment and do the right thing, whether it comes to mayors deciding when to open the city, restaurants being able to dine inside or not, whether health clubs can open, whether schools can be on site or not, and how many students there. This is all temporizing, and we're waiting for the vaccine. We're basically marking time in a ostensibly thoughtful and useful way while we're waiting for the vaccine. But nobody has the right formula as what to do. All we're doing is we're improvising on a step-by-step basis. Relax the restrictions somewhat, keep your eye on that R rate of infection, and if it doesn't go up, then relax a little more, keep your eye on it, and all the while be enforcing or encouraging as strongly as you can that everybody do their part to keep a distance, wear masks, and everything else. But the big solution's really the vaccine. And, it's like in past enomics that most of the people alive, haven't been alive to experience, whether it was polio, whether it was influenza, whether it was smallpox, whether it was AIDS. These are things that have been occurring in the past and we're going through now, but because of science, they don't last as long as these things have in the past. We're going to get a solution, but it's going to take a little bit more time.
Thank you, Jeff. We're going to have to go to a break, but thank you for talking to Dr. Jeffrey Lieberman, Chair of Psychiatry at Columbia University. We'll have you back. A friend of mine, thank you for joining us on Dr. Radio Report's Wise Words. We'll be right back.